our first topics in geriatrics and gerontology for the year. As you know, this is usually held on a Thursday afternoon, and I appreciate your being able to come out on a special day, but it's for a special occasion for a special visitor. Our first speaker for this year, we're very honored to have Dr. M. Powell Lawton here from Philadelphia, where he's a professor of psychiatry at Medical College of Pennsylvania and director of research at the Philadelphia Geriatric Center. Dr. Lawton has his PhD from Columbia in clinical psychology, and he has a long and very distinguished career in looking at a number of aspects of quality of life, environmental studies with respect to aging. His research has been acknowledged by the gerontologic community internationally, and he is the recipient of the Kleemeyer Award by the Gerontological Society of America in 1981. I'm not sure if you were a contemporary of Ed Mazerow at. Oh, okay. Well, I'm sorry I can't tell you that there are two Kleemeyer Award winners in this lecture hall, but Dr. Mazerow is in Italy, so he will not be attending. Dr. Lawton's going to speak to us this afternoon on quality of life considerations in long-term care and considerations at the end of life. For those of you who are interested in attending our 12th annual Geriatric Medicine Conference tomorrow, Dr. Lawton will have the keynote address there on nursing home environmental issues and how they can be used positively for long-term care residents. And if you ask nicely, I'll bet you Dr. Garrity would even allow you to attend without paying too much of the fee. So in any event, we're very appreciative of having Dr. Lawton with us today.
Thank you very much, Dr. Katz. Let's see, I have a job to attach this equipment first. And, well, the pocket, maybe. I've spoken and written quite a lot on quality of life from many perspectives, and I'll repeat some of that today, which I hope you'll tolerate. But a special direction of my interest recently has come in the kind of the confluence of the general community's interest in defining quality of life and how one can attain it for its own sake, on the one hand, and on the other hand, the many ethical and procedural issues that have come about in relation to the end of life, prolonging of life, and so on. And as you all are obviously very aware of how quality of life has become invoked as a critical feature of life extension. I think what was the beau mot that the Gerontological Society adopted many years ago as a sort of a slogan? What was it? Quality, not quantity of years, or something of the sort. And this has become a very central consideration in a lot of thinking about how one manages care during the latter end of the lifespan. The living will, the advanced directives, how one manages to get the wishes of the person more formidably into the decision about what kinds of treatments and what kind of non-treatments to go on, have been always a critical issue. Seems to be what's the quality of life that is a factor here in the helping the person make the prospective quality of life in helping the person make a decision, the perceived, the externally observed quality of life among professionals can visualize as they go about their work. Well, I think that there's a dominant, I'd say there's very good consensus that one must look at quality rather than quantity of years as one of the factors in making many of these decisions. And I'm sure that some of you are aware of a now at least 10-decade or more old streams of research on defining on health decision making, as you might have, that's defined in terms of the degree to which a person may be willing to give up X years of life at a lower quality in return for Y years of life, fewer years of life of a higher quality. The so-called time trade-off approach typically performed in the research setting will give a person a scenario describing a condition, let's say a common clinical condition, and the scenario will describe how much disability there is associated with the condition, in terms of ADL performance, how much pain there might be, whether the person's mental state is affected or not, how long the condition might last, and at what level. And the subject for the study will attempt to make some judgments about how long would you want to live under this condition. One of the conditions is change. Let's say that one of the psychiatric condition is changed from one that might have specified mildly depressed. Under another scenario, it might appear as not depressed. And a series of ratings are made. This is some very sophisticated methodologies have been applied to this kind of research, but the bottom line ends up with the ability to estimate for given conditions what the trade-off in chronological years might be in return for a better quality of life. Now, this is I think we've learned a great deal about how people about these kinds of decisions and in how people might respond to a trade like this, but it's all been research oriented, and the interesting thing is that almost all of this research has been done with subjects who are themselves healthy individuals from the adult range of the lifespan, and it's very, very seldom that we have had any attempt to extend this kind of research to people who are actually afflicted with a particular condition. I'll give an example of one of the interesting exceptions. One group of researchers did a study of renal dialysis and kidney failure. And they gave the typical scenario of what the intrusions on quality of life might be if one were on dialysis, what it would cost in terms of time, the outlook, and so on. And the result here came from the result was one whereby this normal group of people was willing to trade off, I forget how many years, but certainly some years of life to if they could engage in a treatment other than dialysis, even though dialysis might prolong their lives. Well, the same scenario was given by these researchers to people who were actually suffering from renal failure. And the interesting thing about that is that these people, these insiders, people who had some clear idea of what it was about, They obviously were able already, in the state of their illness, they were able to visualize what the costs of enduring the illness might be, but they were willing to trade off very substantially fewer years of life than was true for the people in the general population. So right away, you know, this gives me a kind of an uneasy feeling that we don't really know a great deal about what we're talking about until we've been very careful to expand the range of people who are providing information on the trade-off of quantity for quality. Another problem with this research, in the scenarios that I've described, you get the picture that there are costs to extended life or to treatments of one kind or another, and they are reductions. They're all reductions. Reduced ability to engage in activities of daily living, depression, sometimes, once in a while, not terribly often, but once in a while, there's a reduction in social skills that's included in the scenarios here. These are all intrusions on quality of life that are offered as conditions for making judgments about how life gets extended. I have seen almost never any attempt to do research that would try to learn what are some of the positive aspects of additional years of life that might be factored into it. I look at this whole process as a sort of a mental calculus that people go into, and I would at least like to know. I don't have data on hand yet to show it, but I would like to know, for example, whether an especially rewarding marriage or a hobby that or something that a person is waiting for, like the Phillies ever to win a pennant again, things like this, to positive features that get put into this equation and make one go through a kind of a mental process that might say, well, you know, I know that things are going to be bad here, and the pain, I have some idea what the pain will be like, but there's something else that I can put in here that makes me concerned about it. The typical health decision-making research has simply not included factors like that. So that's sort of a setting in which I'd like to present a little bit more of what I consider is a more rounded picture of the types of quality of life that need to be considered as one enters into research like this. I'll give a few findings from an interesting study that we did of the last year of life. I have to say, it was a retrospective study. We did not manage to get primary data on the last year of life from the people who had passed away. But we have there are some interesting data here that give a better idea, I think, than we have before, just what these processes that people go through in the last year of life are, and maybe what we need to know more about as we consider how we counsel individuals, or how the kinds of information that we give. I have a conception. Let's see, can I walk with this thing? Yes.
I think it's just the other.
Okay. I have a way of looking at let's see what's going. Oh, you got that.
Well, yeah.
Okay.
You want it.
Fine. Okay. Right. Get out of the way here. I think that we have many facets of quality of life that must be examined before we think we've done our duty in defining quality of life. Very often, I've mentioned some of the specific aspects, but basically, I'm talking about two external aspects of quality of life, aspects that are directly observable from the outside and presumably can be judged in terms of social norms. This is the so-called objective environment and behavioral competence. Objective environment means that it is just what it seems to say. And we do have, to some extent, we have definable criteria by which the quality of an objective environment may be determined. As an example, we have the American Housing Survey done by HUD periodically has a list of about 22 housing defects like leaky roof, etc., that can be observed, they can be counted, it can be classed as an aspect of the objective environment. We have many more examples that I just won't bother to go into. An essential thing to remember about objective environment is that this is now irrespective of the needs of the person, of the perceptions of the person. In order to get into that level, we have to go to the subjective side, which is psychological well-being and what I call perceived quality of life. For every aspect of the objective environment, there's an internal subjective region or dimension that is the way the person perceives that objective reality. Everyone who's worked with older people has probably come into contact occasionally with the one who lives in an old car or in a very dilapidated home, who doesn't notice most of the deficiencies that go along with it and is terribly attached to it and will not get out. I think the disjunction between perceived quality of life and the what can be called the objective environment is very clear there. Objective environment, of course, can be is not limited to the physical environment. It can be social too. So that when we're talking about objective indicators of the social environment, our surveys very often will ask, how many relatives do you have? How many children do you have? Tell me who your friends are, and they count them. And these, in a way, are sort of countable externals that have some that can be, we arbitrarily define that more relatives is better, but it's a sort of a rough indicator, and clearly we need to, when one gets into how satisfied the person is in relation to the marriage or the quality of friendships, one gets into the subjective side. Now, behavioral competence I spoke of as being also in the objective realm because we do have, am I doing that? No. We do have socially mandated criteria for what is adequate performance. And I'll just put on another I'm going to go back to that one, but this is hard to read. A hierarchy of behavioral competence. I've suggested again that I can't spend real time on this one, but for each of our areas of well-being, I've suggested that there is an internal structure within each. So I've tried to account for all of the aspects of personal behavior and that can be objectively observed and for which we have some kind of measure of quality. And I mentioned clearly at the most basic level, there's cell health and going up the that's sort of a hierarchy of complexity that goes up the vertical axis there. And I tried to range just some illustrations of the many facets of an individual behavior that can be measured either through, through our laboratory tests or more likely performance tests, and evaluated to some extent. So that this is just an example of what the how one can differentiate within some of these, within the four sectors of quality of life. And in terms of with our geriatric population, for example, just as an example, in behavioral competence, the most familiar realm is activities of daily living. That's measured by everybody. It's a good, reliable indicator of a whole lot of things. The actual adeptness with which a person performs the activities of daily living may or may not have some subjective correlate. Just because a person is an expert at housework doesn't mean necessarily that they have a high perceived quality of life. But that again, it's the two facets are related, but not but far from perfectly correlated. Now, my suggestion is that the last realm here, in this one in the subjective realm, psychological well-being, as a psychologist, I sort of, I feel as if I would argue that psychological well-being is the end point, toward which quality in these other areas contributes. I think that's not a necessary part of my suggestion of the whole conception here. What is important is that I think that that if we fail to take account of quality in any of these areas, we're missing a part of the total life of an individual. And going back to our health decision-making research, most often ADLs are included. The concept of pain, is usually is more subjective than anything else. So it's clearly a perceived quality of life. Depression belongs in the psychological well-being realm, and maybe or maybe not we get into the objective environment. Certainly if we're talking about treatments for illness, chemotherapy, dialysis, hospitalization as opposed to treatment at home, these aspects of the objective environment certainly can become a part of the usual way in which health decision making is measured. But what's missing then, I go back to my thought that there are positive aspects of experience that need to be taken, that are inadequately taken account of. And many of those aspects of experience are in the realms of behavioral competence, objective environment, and perceived quality of life, but they converge on a whole realm of psychological well-being. I'm talking now about sort of, as if you visualize a kind of a causal model where these things are leading into the end state of psychological well-being. Many of you, I'm sure, are familiar with the stream of research that's dealt with what's called positive affect and negative affect. For the any of you who haven't come across this is long years ago. Norman Bradburn made an interesting discovery in some survey research. It was a study of happiness, and he developed separate indicators of what he called positive affect, things that made a person feel up from normal, elated, gratified, proud, attributes of that type, and a separate little scale that measured negative affects, depression, discouragement, feeling criticized and so on. The interesting thing was he found that both the scale of positive affect and the one of negative affect were good predictors of happiness, but the two were not related to one another. That is, positive affect was not at all what you had if you had no negative affect necessarily. They were zero correlated. That there's been a lot of research on that over the years, and that particular finding has been moderated in many ways. But I think that slowly, over 2 decades now, we have come to a greater realization of the potency of this two-factor concept of psychological well-being and the importance of the positive side. I think, though don't pin me down to any neurology here, but I think there is clear evidence that some of the brain mechanisms associated with positive affect are quite different from those associated with negative affect. The journal I edit, Psychology and Aging, will shortly have a very interesting article come out showing that that negative affect has a very strong hereditary component. Positive affect has just a very tiny hereditary component. And again, this gives us some interesting hypotheses about what, creating objective environments that may enhance positive affect. Coming down to the sort of the bottom line here is the thought that we do the things that increase positive affect don't necessarily minimize negative affect, and the things that cause negative affect don't necessarily take away the positive aspects of life. And what we come across, some of my own research and others, for example, has found that the amount of association one has with friends is significantly correlated, not surprisingly, with positive affect. The more friends, the more contact, especially the more close friends, the higher the positive affect. Having friends is irrelevant to negative affect, to depression, to many aspects of mental health. And same thing is true of involvement in external activities, where the so-called activity theory in aging has established pretty conclusively over the years that involvement in activities outside the self is associated with good mental health, but when you start to differentiate the mental health that it's associated with, it's much more like, and you take account of health, physical health, get that out of the picture, your activity, your involvement with things external, it's positive affect that it's much more likely to be related to, rather than being able to undermine the more negative aspects of life. So in the attempts to relate quality of life to healthcare decision making, it seems to me that it's very definitively established that all of these intrusions in quality of life certainly have some clear undermining effect on on negative affect. It's not we just have not given a sufficient chance to see what the things on the other side of the ledger will do. I gave a few examples of the kind of thing I mean, but a whole unresearched area, for example, is what does it mean to have plans or projects to do in one's head? We did a little, just a small pilot survey for a research grant that I have pending now, and we did go around asking our nursing home residents, do you have any plans for several years from now? and we asked them in another place, we gave them a little definition of a personal project, which I can't remember now, something like a personal project is something that you're engaged in that can take a long time or just a short time, but it's something that you know you're going to do and you want to finish. Do you have any personal projects? And it was even the people in the nursing homes, about half of them knew exactly what we were talking about and could tell us something about their plans and projects. And again, this having something, an expectation for the future, is not something you can measure very easily, but we're going after it to try to determine whether putting that in the pot along with everything else would give us some different kinds of equations by which to judge people's attitude toward life extension. Well, in the midst of all this, then I've got, I have a four-way conception of quality of life. I'm talking about psychological well-being as the end point here, but our pilot studies, as well as other, a variety of other more informal clinical experiences that some of us have had, have led me to the idea that there's yet something beyond psychological well-being that we could call valuation of life, that that's terribly slippery. And I think that any of you are on the body that reviews my research grant, please listen. My suggestion is that there is a kind of a jointly, cognitively, and affectively determined position that people take as to whether it's worth their while to keep living or not, that's only partially determined by poor physical health, by a bad environment, whether it be a nursing home or whatever, that the evaluation of life is also determined by this whole series of positive things. And I think that I even feel that one, at least theoretically, I'd like to test out, is it possible for a person to be even depressed or anxious in mental health, in clinical terms, and still have this feeling of something to live for? So that's not measuring the something to live for. I'm talking now totally out of theory because I haven't successfully done it yet, but this is where I feel that we need to go in the future. Let me just illustrate very briefly now from the study of the last year of life that I spoke of. We very briefly we sampled death certificates in the city of Philadelphia and located survivors of decedents over 65 who were willing to be interviewed. We, our yield was only about 50% for the total, so we clearly can't say we're talking about a really random sample, but we tried to put together the best way we could of getting our survivors. They were often spouses, if not spouses, mostly adult children who had survived the person who had died. We tried to get them to make estimates of these major areas of quality of life. And I'll just show you an obvious, where am I here? Is this? We asked them about all the typical activities of daily living, and we compared the group of, we compared the last year of life, those are the solid lines, over the period of 12 months, with a group of people who were still alive. We had the awkward situation that how do you, we were interviewing informants about our deceased people, so we had to, we had this really unpleasant recruitment process of locating elders who would give permission to us to then locate an informant for them and ask the informant about them. Well, we did manage to do that, and that's what the dotted lines are. So what we're doing is we're comparing, we're getting informants, exterior observers' judgments about these qualities of people who had spent for each of the months during, in the one case, the last year of life, in the other, the past 12 months. And you know, you can see very clearly this is only what you'd expect. There's a decline in every one of the ADL functions. The decline becomes precipitous at 3 months, and that's not surprising. We have let me see, I have another table somewhere. Oh, here we are. For a more complete picture, however, this one's a cluttered table, which I'll just speak of illustratively. We tried to make some a priori judgments. You see, the columns there are indicators of quality of life. That's these are basically 7-point ratings that the informant made as to the degree of pain, the amount of alertness, the ADL capacity, the amount of social behavior, the satisfaction with the way the person spent her time, the amount of null behavior, that's doing absolutely nothing, depression, the amount of interest in the external world, and you know, something that we called hope is the way we defined it was how much did the person feel as if there still might be something to live for. And so that's my one attempt to measure that bottom line. So what we did was we have the months again from 12 down to the 1 month before death. And we established a criterion in each of these areas of quality of life as to what positive quality might do. And this was, this was a kind of a clinical a priori judgment. That is, our pain scale, we divided, we had the 3 most severe pain points were arbitrarily defined as low quality of life. The 3 less severe ones as not as high quality of life, and we had to have a different criterion for each of these, and we simply added up tried to determine the proportion of people at each month who met the criterion for high quality of life throughout. And as you see, at the very beginning of the time, the 12 months, almost 2/3 of them were not experiencing pain of a kind that would qualify for poor quality of life. 90% were alert. 71% were unimpaired in ADL, and so on. You go across that way. Regularly, of course, as you go down, as you get closer to death, I think almost all of them decline. However, social behavior, that's not a significant decline statistically as you go from 74 down to 67. And the interesting aspect of that is that at least in this sample, as reported by our informant, there was not evidence of this social withdrawal from the person during the terminal phase of life. I interpret it that family increased, as many people increased their visiting as decreased it over that period of time. So one can go straight through these, take interest in the world, decreased only very little until quite late in the trajectory. Even depression, 1 month before death, we had to, for depression, we deleted the people who were in a coma at any point in the trajectory. There were a lot who could not be judged for some of these because they were too impaired cognitively. But with all those people removed, nonetheless, 2/3 of them, at least the relatives said that they were not depressed even in the last year of life. So you get we have another, just simply trying to summarize across the whole realm of areas of quality of life. There are very few of them where as many as half drop into the low quality of life even at the end of life. ADL is clearly there. Pain does deteriorate. Those are about the only two that even get below the 50% of clearly low quality of life. So again, I use this the findings from this study of the last year of life simply to suggest that it may very well be that the stereotypes of the well and our fears of both poor health and especially of death in the last year of life may help us magnify the intrusions on quality of life that come from physical illness. And my own, speaking just for myself at this point, I am a little bit suspicious of the zeal for advanced directives that comes from the young and healthy. And I think that when we see data like this that show that there is some reason to think that there are at least some people that approach death or illness, or if we had the data, I would suggest intrusive treatments as well. Approach these matters with some vestige of quality of life, compensatory positive feelings of one kind or another, that at the very least it's incumbent on us to provide for things like changes of mind over a lifetime, for devising techniques. I think we need a lot of research on how do you find out from a marginally competent person or a very sedated person or a person in great pain. How can you get that person's introspections about how they feel about the a variety of aspects of quality of life? The easy way of an advanced directive, I think we have to be, we simply have to be cautious about and understand that it's a lot more complicated than making a decision at one point and banking too heavily on it. I've gone on much too long, I'm sorry.
I'm just going to comment on some of the work that some of us have done here also in our own nursing home, trying to look at persons who on standard functional status scales would be considered to be highly dependent and extremely functionally impaired and even moderately cognitively impaired. We were very interested, we did a survey of these individuals and tried to look at their ability to decide about decisions about the end of life in terms of treatment seeking and also in their consistency of decision making even at the lowest cognitive function levels. And it was very interesting to me that these extremely impaired people, the majority of them perceived that they still had something to live for, somewhere in the range of 70%, still had something to live for and still wished to receive many intrusive treatments, as long as their health would not deteriorate to a status much below what they were now. And even the most cognitively impaired persons were able to rationally stage the desire for treatment down as the scenario for quality of life decline. So even persons who scored very poorly cognitively were able to say that in a vegetative scenario they wanted virtually no treatment, but in their current health scenario they wanted many treatments.
And the current health scenario was certainly not necessarily what you'd call good health either.
No, these were people who had terrible scores
Yeah.
on activity of daily living indices, and also about half of whom had significant depressive symptomatology, although we don't know that they were depressed. But they had significantly high scores on the geriatric depression scale. And many of them persisted in wishing to want to live.
Gosh, I think that's the kind of research that, I think that's right on target, is the kind of thing we, not just research, but clinicians need to, I think, test the limits of what they can learn from people in these states.
The question in my mind, though, Dr. Lawton, is often the treatments which we might have to offer to individuals who still perceive their quality of life as sufficient to continue to want to live, the treatments we may have to offer them in the case of serious illness may in themselves be fairly futile. And so we ask them about advanced directives and ask them about their preferences for care, but in fact we are often offering them futile choices. For instance, particularly about cardiopulmonary resuscitation or mechanical ventilation. We're in this dilemma where we wish to take their wishes into account, but we ourselves as clinicians know that were these therapies offered to them, fewer than 1 in 100 of these nursing home residents has any chance of surviving and having a meaningful life.
I mean, it seems to me that those are the considerations that, that are the realistic bases for decision making. I feel that quality of life has been overused. Poor quality of life has been overused as a rationalization for not trying enough with the nursing home resident. Now, the judgment that that the treatment, the probability is infinitesimal, of course, has to then influence what's actually done. But I don't like the making of our professions feel better by saying that they would have a low quality of life, so it's justified to not to at least consider these possibilities. Yeah.
Do you have any thoughts about stability of perceptions of quality of life over time or over a lifespan?
Well, to some extent, they're too stable almost. Yeah, of course, we have a lot of the Baltimore longitudinal study has data showing that some personality measures taken 20 years before were very good predictors of a lot of current behaviors. So that there certainly, there are personality variables that I think are very stable over time. But the interesting thing about positive affect is that it's less stable than others. And, there's just all kinds of fascinating instances about it, as the study I quoted on genetic aspects of quality of positive and negative affect would suggest. The positive affect does seem to be very dependent on the situation going on around them, and yet positive affect is one of those things that people use to, to compose their decision about whether there's hope left and that sort of thing. So I think that we, are different. There are emotional states that we have to be very concerned with, but they are superimposed on fairly stable characteristics that I don't think that any of our interventions can change the basic personality traits of extroversion or neuroticism, for example. But certainly the immediate situation has a lot to do with how much positive feeling and negative feeling is coming on at a given setting. Are there other comments?
Just a comment, I think the optimistic tenor of your talk really parallels the progress in biological development to the extent that the more we seem to find out about physiological changes, they seem to indicate that decline of all physiological systems is not inevitable. an inevitable consequence of aging, and that in the absence of significant pathology, in the presence of good nutrition and lifestyle, there are a lot of healthy older people around.
Right, right.
So I think the stereotypes are changing both from a behavioral point of view and a physiological point of view.
Well, I hope so, and I think that there's. I don't know that side of it particularly, but that's certainly been the my quarter of a century in aging, so to speak, has certainly demonstrated that. Yeah.
It's interesting that in the barrier maintained animal facilities here, that there are certain predictors of the last few weeks of life, I guess. They're like they stop eating.
I think the classic slide of Nathan Schock showing all the physiological systems going down at a very rapid rate is being modified considerably in the light of evidence which has come out in the last couple of years.
Yeah, I think that had he put clinically manifest pathology into each of those curves, they would have flattened out considerably.
Other questions or comments? Yes.
Not being real familiar with this whole area of research, as a clinician myself, I have done some reading in the popular literature along these lines. I'm sure many of you are aware of Scott Peck and some of his writing, starting with the robust Powell back in the 70s. And I think his direction is really right parallel with what you've been talking about, and that is that what we think is going to hold promise of meaning in life can't just be placed into the rubric of positive didactic. You have to include both, because a lot of growth in terms of value for an individual person must come through what he might call suffering or negative experiences in life, and then perhaps even more so during the late stages of life, do people have an increase in their frequency of negative experiences, both from a health standpoint and also relationally. And it's interesting, I think, that the last book that he wrote, called The Man by the Window, takes a first-person viewpoint of a group of nursing home residents and going through a series of experiences that, were we not allowed to have that worm's eye view, so to speak, right inside the nursing home, most people, and particularly clinicians, I think, might have concluded very, very different things about the meaning that those same residents attached to their existence at that point in life. And these things are easier to read, perhaps, than some of the technical data, but what Peck has done is, I think he's raised the consciousness of this problem and the difficulty with which clinicians oftentimes approach the questions that they are the main ones that are going to have to answer in terms of advanced directives, durable power of attorney, DNR decisions, that sort of thing. I would think that the ones who should be most apprised of these developments and most aware of the importance of both negative and positive affects, to use your terminology, should be the clinicians that are making those life and death decisions.
Well, I would love to see clinicians work on extracting the meaning that residents of nursing homes see in their lives. It's a hard thing to do. I mean, when I spoke of trying to get people to talk about plans and projects, those are abstract concepts, as is meaning in itself. And I think how do we get people to know what you're talking about and to feed back to you some information about how what meaning there is in life? I don't know. Do you have any?
Well, it seems to me that it's a lot less important how skilled a clinician is in technical matters or how scientifically grounded he is than it is to be perhaps trained in certain relational issues. not how to take a history necessarily, going through your rubric of your algorithm of, chief complaint, history of prevalence, past medical history, surgical history, transfusionology, and so, you go down the whole thing through your physical, you look at the lab and all the tests that you want to do, and you come up with a conclusion. That's what we're trained to do in medical school, but what we're not trained to do, even after medical school, during the residency period in most cases, is to learn how to really listen to the patient in issues of meaning and value for that patient. And those are the issues around which decisions about the end of life revolve. Much more than biological or medical questions of health.
Well, I certainly couldn't agree more.
My ideas would be simply, at the medical school level at the very least, to start to incorporate some of those priorities. And I am involved in teaching at the residency level. So certainly this is a very real issue for me, and I try to emphasize that, but it's not part of the curriculum. If you could even use that term, I mean, this could hardly be something legislated or, scheduled. It's something that you grow with. The priority has to be there, I think, from the highest level.
Is there still a reluctance to talk about death and the expectation of it, you think, or is that sort of gone by now?
Well, I don't know if I'd use the word reluctance. It's just...
I mean, to broach the subject with a patient.
Every resident is so busy, dotting I's and crossing T's that they just don't talk about that much. I mean, they have one individual patient who's in the ICU on a ventilator, and yes, then all of a sudden these issues come up, and all of a sudden they're wondering, who the nearest of kin is, and whether the patient's still married or the wife is even alive, and how many children there are, whether these children are going to disagree about whether to do this or that. But those become more mechanistic issues in order to implement the decision-making process rather than issues that hold their own importance and their own value apart from the medical decision that has to be made. So I would answer your question that very little thinking is done about that.
Yes.
I have a slightly different experience. Psychiatry residents are taught to elicit meaning from clinical interviews. In my experience, it's an inherently dangerous undertaking because you can extract several different meanings from the same interview. And it often says more about the interviewer than the patient themselves. An example of that would be the revision of the past literature on life events to take account of the fact that elderly people may experience the same life event differently if it's an on-time event, an event that may cause significant disruption at a different age or a different cohort. But for instance, losing a spouse in a 20-year-old would be much more disruptive to one's life than a spouse at the age of 80. And Osler said, when in doubt, ask the patient. And I think that's the fundamental weakness of quality of life research is this idea that we're trying to elicit this meaningful information from a patient who may not be competent to make those decisions. And it makes it just fundamentally a very difficult task. And as you said, Dr. Lawton, this information is valuable to the decision makers. You're already saying that the people who are actually making these decisions are not the patients themselves. And I think it's for the same reason that it's very difficult to know whether these people can make these decisions and whether we're reading them right and fit that into our agenda and trying to provide the care. I think it's just a minefield of complicated issues here.
But who better to make them?
Do what?
Who better to make them or get the information from?
Well, no, I just mean it's difficult to know what it is you're actually measuring and who's, ultimately you'd want it to be the patient making the decision that this is their quality of life, and not us trying to map variables onto what patients would feel. And I think that there's so many different things that change the way a person puts meaning on a particular event or a particular situation, that it makes it very difficult to do this kind of research. And I admire the way the people who do it try to strive for some sort of objective standards by which to measure these things. But it's just a very difficult undertaking.
To say that it's difficult to discern and full of unreliability and capacity, a possibility of projecting one's own rather than the patient's solution, that really is not to say that it's not worthwhile trying to extract something anyway, is it? I mean,
I think, it's good to be doing it. It's just an inherently difficult task. And the nursing home in particular, because those are exactly people who may not be fully competent to make those decisions. And we're trying to read through. An example is that I teach my residents, patients are referred to me all the time for depression because they cry frequently. Families label that as unhappiness. Residents mistake that for unhappiness, when in fact they have disinhibited crying from subjective force. And the behavior crying is divorced from the patient's subjective experience. And when you actually ask the patient, they say, "No, I'm not sad. I just don't understand why I'm crying." And it's not.